tonight in this nasty weather. I'm so excited that we have so many people here tonight. It's really great. My name is Alyssa Krause. I am a volunteer with the Campaign for New York Health, and we are co-sponsoring this event tonight, along with the social justice team of the Unitarian Universalist Congregation of the Catskills, the Citizens Action Hudson Valley Chapter, and Ulster People for Justice. We are really pleased that we have such a diverse group of co-sponsoring organizations tonight. What we're going to be doing tonight is talking about the New York Health Act as a social justice issue and also as a practical issue for us to learn more about and do something about. We have a very exciting panel of 5 speakers actually. We're going to start, and I'm going to give you some background on people. We have 5 speakers, and our first speaker I'm not introducing, I'm just going to tell you who they are. Our first speaker will be Jess Roby. Jess is a registered nurse here in Kingston. She worked at Family for many, many years, and then became an RN and works at our local hospital here as a bedside nurse. She's an advocate and a provider, and she has a front row seat to the gaps in service that cause people's lives, problems in people's lives, the gaps in medical service. Our 4th speaker is seated here. Jess is going to give you the overview of the New York Health Act, how the New York Health Act would work, why we need it, and even ultimately what we need to do to get it passed. Our speakers tonight include Dr. Randall Rissman. Randy served as a Woodstock family practice practitioner for 36 years. He founded the Maverick Family Health, which is now part of HealthQuest. Those of you who know him know that Randy's been a long-time activist in this community, and among the things that he's done to contribute to affordable health care is organize a group of 75 doctors and other medical practitioners to lobby John Faso last year to help protect the Affordable Care Act.
Not that he was good.
But you know, we're all here working on it, right? Yeah, next is Jean Lenzer. We met Jean when we were tabling at the Y, asking people to sign up and help support the New York Health Act. And come to find out that she's an award-winning medical investigative journalist and a longtime contributor to the British Medical Journal. She had just published a book called The Danger Within Us, which is about America's untested, unregulated medical device industry. And she told me that the last chapter in her book was all about how her reason for writing it is her support for single payer. So I read that chapter, and I thought she has to work with us and help us in this movement. So I invited her to speak. Next to her, Father Frank Alaya, who many of you know from here in Kingston, is the vicar at the Holy Cross Santa Cruz Church in Kingston, a bilingual, multicultural parish. He successfully worked with Kingston clergy and others to persuade the Kingston Mayor and Common Council to adopt a memorializing resolution declaring the city welcoming and inclusive toward undocumented immigrants. Wow. He has also worked tirelessly with other members of the church clergy, both to obtain sanctuary places at houses of worship and to struggle against unjust police practices. Mm-hmm. And finally, we have Reverend Julius Collins, a longtime Ellenville activist and recently elected Ulster County legislator. Yeah. Reverend Collins told us the other day, he's had a really long history. He's been on the school board for many years, and he's on the board of a hospital. He was a career military man. He's the pastor of the Shiloh Baptist Church. And this past year, he felt that as a matter of conscience, he had no choice but to enter electoral politics. And that's why he ended up, luckily for us, as an Ulster County legislator. We have... I'm really thrilled that we have this opportunity to talk about single-payer health care, affordable care for all New Yorkers from the many different perspectives that our 5 speakers are going to bring to us. On each of your chairs, you found a packet of materials. One of the things in that packet is a card. We want you to write down any questions you have on that card. We felt like with a crowd this large, I'm happy to say, it would be difficult to have people do their questions from the audience. So we're going to encourage you to write down questions anytime they occur to you. And as we break and we go from one speaker to the next, you can just hold up your card and Charlotte Adamus or Joanna Dempsey will pick up your cards. Let me say that I am not the only volunteer here with the Campaign for Your Health. Charlotte is one. Joanna Dempsey is another volunteer. Jess has worked long and hard for a long time before I even got here to be a volunteer for the campaign. Angela Lears in the audience is another one of our volunteers. Who else? Maggie B. Maggie B. is right there's Maggie. Hi. Is here. Melanie is there.
Yes,
and
yeah.
Chris.
I didn't volunteer there. Julia.
Hi, Julia. Thanks for coming. Our organizer from New Paltz, Cindy New Paltz, right?
Yeah.
Great. And our last volunteer I want to introduce right now is Christine Rawlick. Christine is going to play a very special role tonight. She is going to be the actual moderator for our speakers. And Christine has...
I want to show you my little device.
Christine has a device.
This is a device to keep everybody on time. So when you see this coming out, just think that maybe it's time to perhaps wrap up a little bit. The reason for this is we want every member of the audience to have an opportunity to talk and allow everyone to ask questions from our distinguished panel.
Thank you. And we also want to make sure that we have a good Q&A time period. I also want to acknowledge Jen Metzger, who I know is somewhere in the audience here. Jen is great.
Good news today, huh?
Great news today.
Yeah.
Great news.
Share. You need to share that. Tell everybody.
Senator Bonasek from the 42nd District, who I'm running against, Republican who's been in the state Senate for 20 years and in the legislature for 28 years, announced his retirement today.
So, and I heard that there's another one across the river who announced that she was not, another Republican woman across the river, who also announced that she's not going to be running. So it opens up some real possibilities because as many of you know, we're now in a situation where we have 30, most likely as a result of the special election this week, we have 31 Senate sponsors. And we really have to get that 32. And there's, a couple of ways to get it. And one of them is get some more seats.
Woo.
So,
Are you here because you support this motion?
But I'm also here to learn.
Right.
So with that, we're going to
Right. So what Jess is going to do, as you have announced, is to introduce the bill, explain what it is, what it isn't, and so forth. But we hope, Jess, that you can at the end also, like the panelists, talk a little bit from your perspective as a nurse, why you think it's so important from the point of view of somebody who's in the middle of the healthcare industry. Thank you.
So thanks everybody for coming. Can you hear me okay? Do I need to cozy up to the mic? Okay. So we got a bit of a slideshow presentation for you. I'm a visual learner, so having images helps. But I'm going to talk to you so you can split your attention. I came to nursing from, as Alyssa said, many years of working at Family of Woodstock, where I got to see the variety of cracks that people can fall through. And so I came to healthcare with already that as my mindset of kind of understanding that there's more to the person in the bed than the various physical components. So to me, healthcare is an important issue that transcends partisan issues. This isn't about, are you Democrat, are you Republican, are you this, are you that? This is about a moral issue about getting healthcare to everyone in the state. So if you ask the average American, is healthcare a right, 92% of them will say yes. And if you dig into that little bit of people who say no or they don't know, if you say, hey, if people had to contribute, then do you think it's a right? Most people say yes. That takes up to only 13% of that little chunk that are unsure. So the New York Health Act is a bill that's currently has passed the Assembly the last 3 years ago by a pretty good margin. It's been around since the 90s, believe it or not, 95. And it is now sitting in the Health Committee of the Senate, where it has 31, hopefully, after these special elections, co-sponsors. You need 32 in order to have a majority of people in the Senate in favor, and that would get it out of committee maybe. So we need 1 more seat. And it would cover health care for everyone in the state, regardless of immigration status. So it doesn't matter whether you're a citizen or not. If you live in New York, you have approved residency, you have health care, and it would be covered by a progressive tax that would come out of your paycheck if you're working, and it would use the money we already get in the state for Medicare and Medicaid, the tax money that goes into the Affordable Care Act fund, and some of the, we all pay taxes to pay for the health care of everyone who works for the state, for the veterans. All of that is part of the money we already pay. So it would be part of that plus the tax, and we'll get into that. And then everybody gets the care they need. And it would cover, the idea is that it would cover everything that is currently covered by commercial insurance. So your health care, your reproductive care, your mental health care, all of that would be included in this. So what is it? What is single payer? Does anybody know what single payer is?
You can go to your doctor or your specialist, and the bills go to the government or the state, I guess, and the state pays the bill. You don't have to have all those people figuring out all the different forms, all the different companies.
Right.
It's just bill one place.
Exactly. So it's very similar to the old Medicare before we put in the Part D and Part G and LFO and whatever, where you went to the doctor, you had a service, the bill went to the state paid the bill, and that was the end of it. So that's single payer. So does anyone know the difference between single payer and socialist medicine? Because there's a lot of confusion. Sometimes people get those two confused.
Well, with single payer, you choose the doctor you go to. Socialist medicine suggests that you have to go to the doctors that the government selects and provides.
Right. Yeah, so
they're not private providers.
Right. So in this country, we have a socialist medicine system. It's the VA. So if you're in the VA, you have to go to the VA to get your care. If you go to your regular doctor, you have to pay out of pocket. So socialized medicine is where the state or the government owns the hospitals, the doctor's offices, and all of the doctors and nurses are federal or government employees. In a single payer system, it's still a private, the hospitals are privately owned, the doctor's offices are privately owned, the doctors and nurses work for the companies, but the bill gets paid by the government. Okay. So it changes the game. Right now we have a health insurance system, and this would make it a health care system. It takes profit out of it, so we're not looking at how much money can the health insurance companies make. Right now they insure you, but they owe their stockholders and their shareholders a profit. So this takes that out of it. It gets rid of the game of my doctor thinks I need an MRI, my insurance company says no, I need to have an x-ray first, and then I have to go get the x-ray, and then they say no, we're not going to pay for that, and so it gets rid of all of that. And it no longer says, well, if you have CDPHP, you can go see this doctor, and if you have MVP, you can go see this doctor, and if you have United Healthcare, you can go to this doctor. You can just go to see a doctor, because every doctor takes the one insurance company. So it levels the playing field. So under our current system, we pay more than any other industrialized nation for our health care, and we get less. We have worse outcomes. You can see this is us compared to some of the other major industrialized countries. So just to clarify, we all pay for public health insurance. And if you're not getting Medicaid or Medicare, or you're not on the Affordable Care Act, you're not getting the benefit of that directly necessarily. So that $6,470 we each pay, that already we're funding a public health system. And then on top of that, we pay, if we have our own insurance through our employer, if we're paying into a system for the, what do you call that thing?
Exchange.
The exchange. you're paying in addition to that. So we spend roughly 10 grand a person in this country for healthcare, which is a lot more than like in the UK, they pay about half that. And then that doesn't count our medications. So then we also pay for our pills on top of that. You can see we pay a lot more. Partly that is because our insurance companies have overhead, right? So United Healthcare has to make their pretty flyers, and they have to have their pens that they give you in their little squeeze balls, and all of that stuff costs money. They also have to pay for their employees and the offices where their employees sit, and the internet connection their employee uses, and the phone and the fax machine, and all of that costs money. In single-payer systems, that doesn't exist, which is why we pay so much more than everyone else does. So the other part of this is that since the 70s, when this private insurance market really kicked in, our administrative costs have ballooned. So that's that stuff. That's the, I'm a doctor and I'm one doctor and I have 3 people at the front desk to handle my medical billing. That's all administrative costs. So in a single payer system, you don't have all that negotiating that has to happen, so you don't have all that administrative costs. So you can see the red part is that administration expense, and if you look at what doctors, even though that's increased, it's kind of not as much. The administrative costs. And this is part of the other piece of it. So I just want to highlight, these are some of the CEOs of some of the major insurance companies. These are not yearly salaries. These are per working day salaries. Okay, so that's $80,000 per working day. So that's why we pay so much for administrative costs. And for all of this expense, we actually have worse health outcomes despite the fact that as a country, we smoke less than other countries, we drink less than other countries. We kind of do these things that supposedly are going to make you healthier, but they actually don't for us. And even though we're paying more, we actually use the healthcare system less. So as you can see, we have, fewer older people because we die earlier. We have fewer smokers. We have much fewer doctor's visits. So we have people who are not going to see their doctors, who are not staying in the hospital. And I can tell you from working in the hospital, we are rushing you out the door from the day you get in there. So yeah, people stay at hospitals less time now in this country than anywhere else. And you can see that we are much more likely to skip care. So, you don't really go see the doctor because you can't swallow anymore because your throat's so sore, or you lay in bed and hope it's just a cold for the first week before you go get antibiotics. And yet, we live about 3 years less than some other countries. We have a higher maternal mortality rate, and these numbers are even worse if you adjust them for racial disparities and class disparities. These discrepancies are much bigger if you start talking about the Black population or the Latino population. And even with the improvements from the ACA, we still have 1.4 million people in New York State who do not have health insurance. That gives you a little picture of how New York is insured. So if you look at it, we're really already about halfway there in terms of people who are relying on a public option for healthcare in New York State already. We're already paying for about half of us. So we're really only talking about the other half of us. So the core values of this bill are that it covers everybody, that it covers everything that's medically necessary. So there's still going to probably be room here for like your Aflac kind of stuff, or your things where people can buy into other things that aren't part of what's considered necessary. So if you want your plastic surgery or your breast reduction surgery or that kind of stuff is not medically necessary, there may still be other options. But as it stands now, it would cover everything that's deemed medically necessary. You would have freedom of choice of your provider because there's no more networks, and you don't have to worry about deductibles and copay. You can just go see the doctor. It's not going to cost you anything. And it's covered by all of us. We all share the burden. So the funding, we're going to go into this a little bit more, like I said, is going to be the current existing public funds we have, the progressive tax. If you make under $25,000, you don't pay, your employer doesn't pay. So for small business owners who have employees who make less than $25,000. This is not going to be an additional cost to them. And currently, for every Medicare dollar that comes into the county, 50 cents of it is paid by the federal government, 25% is paid by the state government, and 25% is paid by the county. So you spend a quarter, from the county's perspective, you spend a quarter, you get $1. And that quarter comes from our taxes. So under this, that goes away. And so it would be a tax cut for us. We wouldn't have to. Remember when Faso and Collins put that weird thing in the healthcare bill that was going to try to rectify that? So that was what that was trying to address, is that in counties that are very small and have a very big Medicaid bill and not a lot of tax base, a huge amount of the income they get goes into that pot. So that would go away. So this would fix the problem that Faso had. Okay. Well, never good. So the other thing about the way we currently do business is that it's a backwards tax. So it costs what it costs to insure a family. So if you're a family of 4 and you work at a company, it costs, this is an example from a small business owner in the Adirondacks. She, as the owner, was a family of 4, and she had employees who were families of 4. It costs $23,400 a year to insure a family of 4, no matter what your income. So if you're her and you make $164,000, that's about 6% of your income. Okay, it's a chunk, but it's not going to kill you. But if you're one of the employees who makes $53,000 a year, it's 18% of your income. Mm-hmm. So it's the same amount of money going out, but it costs that family a lot more than it costs her. So in our country, the working poor and the working lower middle class pay, even though the dollars are the same, they pay a lot more for their health insurance than the wealthy. Under the new tax, the amount that it costs to insure a family of 4 is different depending on how much you make, because it's based on your income. So, for example, the person who makes $53,000, it's going to cost them $2,500 a year, so $24,000 to $2,500 per year. That's $215 a month. The employer would pay $172 of it. The employer would pay $43 a month to insure his family of 4. Currently, it's $820 a month. Okay, and for the woman who's making $164,000, okay, so it's going to cost her almost $17,000 for the year, but that's only going to be $283 out of her pocket for the year, as opposed to the $820. So even with that larger amount, it's still a savings for her. The blue line in this graph is the current spending on health insurance. And the red is what the assessments would be under the new bill. They intersect at $436,000. So you are going to save money unless you make more than $436,000 a year. And if you do, then you should share. So before the ACA, it was estimated that about 65% of personal bankruptcies were because of medical bills. That's based on why they're filing, when you look at what they declared when they filed. After the ACA, we saw a 50% drop in personal bankruptcies. So we're inferring that even though there were a lot of issues with the ACA, it really saved people from having to go bankrupt over medical issues. So this is based on the economic analysis that was done on the bill. So it's going to cost us a little more money than it does now. So it's going to be plus or minus $26 billion more. However, we're going to save $71 billion in the administrative costs and expenses that we currently pay that we would no longer pay, which means we're going to get about a $45 billion savings, which will help. We can use some of that to help. There are going to be a lot of people who are going to be out of work from this. And so the idea is that while some of them would be absorbed into, we're going to need people to administer this new system, so some of them will be absorbed. But that $45 billion, some of it is earmarked to help with job training and job placement so that we wouldn't leave people out of a job. So some people say, I don't trust the government to do anything right. You're asking me to put a lot of eggs in the basket. But Medicare works fairly well. We're taking the Part D and Part C and everything out of it because that's the privatized part. And a lot of the issues with it have to do more with the bigger piece of our system than the actual administering of Medicare itself. But it's pretty predictable. The costs don't go up that much. It's got about a 2% administration cost rather than the 35% of private insurance. And Canada has a system similar to this. And in Canada, the most popular Canadian is the guy who created their system. So I just want to talk a little bit about how this plays out for me at the bedside as a hospital nurse. As I said, I worked at Family, so I got to sit with people in the Social Security Administrative Office. I got to go with people to apply for Medicaid. I got to walk through the hoops of all of these systems. And the thing that boggles my mind is that these systems are set up so that the most put together, literate, educated, organized human being can just barely figure out what it is they're asking you to do. And these systems are targeted at people who are physically disabled, people who are mentally disabled, people who don't feel very well, people who have limited mobility, people who have a million reasons why they don't have the same address every year. And so most of us who are healthy, we don't really use our health insurance, and the part we use is a pretty well-oiled machine. But when you need your health insurance, when you're really sick, when you don't have a lot of patience, I can tell you people who are really sick don't have a lot of patience. Their family members do not have a lot of patience. People are anxious, they're scared, they're trying to figure out how they're going to pay their bills, they're not working. And that's when you need to spend how many hours on the phone arguing with your insurance company and figuring out the paper you need and getting. So why we set that up, so we have people who are given some horrible news and immediately the dominoes fall between, if I lose my job, I don't have any health insurance. That's the other point I didn't make, is that this is not tied to your job. It's tied to your address. So as long as you live in New York, you're good. If you go travel, you're still good. You just have to live here. So you no longer have to worry about, if I lose my job, I lose my insurance, On the side of the nursing, I can tell you we run a really tight ship. You don't have a lot of extra time to hang out with people. And you get somebody who's leaving, and you need to make sure that you call the pharmacy and make sure that when they get there, the medications that the doctor called in are covered by their insurance, have a copay they can afford. Because I work on a respiratory floor, so everybody who leaves us is on a steroid taper. It means we've been giving them IV steroids while they're there, and they need to go home, they need to take prednisone for a series of days, because if you just stop taking steroids, you put yourself in a major health crisis. So if you leave the hospital, and you get to, even though the steroids themselves aren't usually that expensive, when you get to the pharmacy and they tell you it's going to be $900 for the medications you're supposed to pick up, most people say, thank you very much, and leave. And they don't call us, and they don't tell us, and it isn't until a week later or 3 days later when they go into a crisis and they come back to the hospital, or if they make it to their doctor's appointment because everything's awry with their, hormone system. That's a major problem. So I, as a nurse, can be sitting on the phone listening to Muzak for 30 minutes, trying to get to the pharmacist, only to get and then I got to track down the doctor to say, hey, okay, so here's your list. Pick one of these medications because this is what they can afford. That's a lot of time that I'm not at the bedside, that I'm not paying attention to what's going on, that I'm not doing what needs to be done for the person in the bed. So that's not helpful. Let me go back one more second. The other thing that can be very frustrating is that you know how you have a car and it's making a funny noise, and you take it to the mechanic and it stops making the funny noise, and you're doing your best to imitate. That's how it works for us too. You get to the hospital, things are a little bit different than they were when you were home, and we're trying to make our best guess. We're looking at labs, we're looking at imaging, we're going, well, it could be this, it could be that, and different doctors have different perspectives on how they want to follow up with that process. And then the insurance company weighs in. And the person from the insurance company who's weighing in is someone who has a checklist in front of them that says, like, if this, then this is what we can approve. They're not medically trained. There might be nurses or doctors on call, but most of those people did an online billing class. And so they are the people who are making the decisions about your health care. That's not okay. The doctor sitting in front of you who's looking at your body, who's touching you, hopefully they're looking at you and touching you when they're treating you, those are the people who should be making the decisions about your care. Nurses are supposed to be your advocate. That is one of the primary goals of nursing. And I am here tonight, and I'm part of this because to me, I can't effectively advocate at the bedside if I'm having to advocate on the phone with someone who doesn't know you. And so to me, this is very important that we get it down to where people who are supposed to be taking care of you get to call the shots with you about how you get cared for. It's not somebody else's say in an office somewhere.